This is part 5 of a series of lectures addressing the topic of diabetes mellitus. These are the topics that were previously discussed in the past 4 lectures: introduction, physiology and pathophysiology, classification and diagnosis of diabetes, how to evaluate a diabetic patient, and we spoke in full details about type 1 and type 2 diabetes, including the treatment options and including the devastating metabolic complications which occur in type 1 diabetes, which is diabetic ketoacidosis, and the corresponding devastating metabolic decompensation which occurs in type 2 diabetes, which is non-ketotic hyperosmolar syndrome. The topic of today is one of the very important topics related to diabetes, which is hypoglycemia. Now, in a normal person, the blood glucose level is actually kept at a steady state, because when the blood glucose level increases, this will actually result in increase in the insulin release, and consequently the actions of insulin will be increasing the glucose utilization through glycogenesis, which is the glycogen synthesis of the liver, and lipogenesis, which is utilization of the excess glucose to synthesize triglycerides, and increasing glycolysis. Glycolysis is the utilization of the glucose by the cell. On the other hand, when the blood glucose drops, the counter-insulin hormone, the very important counter-insulin hormone, is the glucagon. Initially, it maintains the blood glucose level through breaking down of the glycogen of the liver and the muscle through the process of glycogenolysis, and then it maintains further blood glucose level constant through enhancing gluconeogenesis. What is gluconeogenesis? Gluconeogenesis is the synthesis of glucose from non-carbohydrate source. So hypoglycemia, when it occurs and the low serum glucose occurs, it results in 2 major types of symptoms. The first set of symptoms, actually we call it sympathoadrenal activation, and it results from the activation of the sympathetic nervous system, release of excess epinephrine and norepinephrine, and this is responsible for initiating the symptoms like sweating and anxiety, tremors and palpitation. With further decrease in the blood glucose level, the low glucose level starts to affect the central nervous system, and the manifestations of low glucose on the central nervous system, we call it neuroglycopenic symptoms. It includes fatigue, dizziness, headache, visual disturbances, and in severe cases, the patient might pass into deep coma. And regarding what are the commonest causes for hypoglycemia, the commonest cause is drug-induced. Whether these drugs are used to treat diabetes mellitus, for example, overdose of oral hypoglycemic or overdose of insulin, or other medications which will act indirectly to lower the blood glucose. Less common causes for hypoglycemia includes certain tumors of the pancreas, which is called insulinoma, or end-stage renal failure or end-stage hepatocellular failure. Any kind of end organ failure, it can result in hypoglycemia, and septicemia. These are the less common causes for hypoglycemia. This diagram, it represents another classification of hypoglycemia, in which we can view hypoglycemia either as endogenous or exogenous. Endogenous, as we mentioned, it can be caused by a tumor of the pancreas like insulinoma, or insulin-independent hypoglycemia like end-stage organ failure or septicemia. Exogenous, as we mentioned, the most common cause is drug-induced, followed by alcohol and toxins, and factitious. What is factitious? Some people with psychological disturbances might inject themselves with insulin, or they intentionally take medications to intentionally lower their blood glucose levels. Now, regarding the drug-induced hypoglycemia, it can work by more than one mechanism. One of them is through increased insulin level, like the insulin or sulfonylureas or isoniazid, or through increasing the sensitivity of the tissues to insulin, for example, like beta blockers or ACE inhibitors, or suppressing the hepatic glucose output, and this is the primary mechanism of hypoglycemia induced by alcohol, or through an immune-mediated mechanism like isoniazid or hydralazine, or hypoglycemia which is caused by unknown yet mechanisms like sulfonyl salicylates and sulfonamides. Sometimes the hypoglycemia is classified according to the measured blood glucose level into three types of hypoglycemia. Level 1 hypoglycemia, in which the concentration of the blood glucose is less than 70 milligrams, but it is more than 54. Level 2 hypoglycemia, when the blood glucose level starts to drop below 54, in this case the neuroglycopenic center starts to symptomatize, and in addition to the sympathoadrenal symptoms, the patient will start complaining from neuroglycopenic symptoms. Level 3, this is the most dangerous one, and usually in this stage the patient is having altered mental status or might present with deep coma. And this table, it shows the classification of the various levels of hypoglycemia. Level 1, level 2, and level 3. Level 3, it's an extreme important item to recognize because sometimes the patient might present with deep coma and altered consciousness level. And for this reason, we always teach our students that hypoglycemia should be considered in any patients with any altered consciousness level or coma or seizures. And the importance of this, when a patient is presenting to the ER in a deep coma, there are more than one medication that should be administered empirically without waiting the results of the lab tests. One of these important medications which should be administered intravenously, empirically, immediately without waiting for the test results, is concentrated 25% dextrose, because if the patient is having hypoglycemia and there was a delay in the administration of glucose, this might result in a permanent cord damage. Hypoglycemia is clinically diagnosed by what is called Whipple triad. Whipple triad should be present if we are to diagnose a situation in which the patient will be having a true hypoglycemia. Whipple triad, it includes, number 1, symptoms consistent with hypoglycemia, whether these symptoms are sympathoadrenal or neuroglycopenic. Number 2, there should be a documentation of a low blood glucose level below 70 milligrams by a precise method, like the rapidly used machines to determine the blood glucose level. The third aspect of the triad is reversal and relief of symptoms once the blood glucose level is elevated. So hypoglycemia, in order to be properly diagnosed, we have to have the Whipple triads. This diagram actually it presents the mechanisms and the compensatory mechanisms which occur in response to hypoglycemia. We have here the hypoglycemia will affect the hypothalamic regulatory center, and the pituitary will start releasing ACTH. ACTH will result in the release of cortisol. At the same time, the hypothalamic regulatory center will stimulate the autonomic nervous system. Autonomic nervous system will result in release of epinephrine from the suprarenal medulla and norepinephrine from the sympathetic nervous system. The other mechanism is that a low blood glucose level will increase the production of glucagon by the alpha cells, and glucagon will act to counter the effects of hypoglycemia through enhancing glycogenolysis and gluconeogenesis. And this is another diagram which represents the combination of the various compensatory mechanisms. We have here low blood glucose level. It will act on the brain when on the level of the hypothalamus, and this will result in increase in the sympathoadrenal flow, and this will result in the release of epinephrine and norepinephrine. At the same time, on the pituitary there will be increased production of ACTH and growth hormone. All of these actions collectively will act to counteract the effects of hypoglycemia through increasing glycogenolysis and gluconeogenesis. Now, the physiological response to decreasing plasma level. What is meant by this topic? Meaning, when you start or when a patient starts to have hypoglycemia, what are the sequence of events which will occur in order to maintain a constant blood glucose level? When the patient passes into hypoglycemia, the first response is the decrease in the insulin production. And if the blood glucose level continues to drop, the second response will be increase in the production of glucagon, and as previously explained, increased glucagon will enhance glycogenolysis and gluconeogenesis. If the blood glucose level starts to decrease further, then there will be increase in the production of epinephrine, which will again enhance the process of glycogenolysis, and further drop in the concentration of glucose will eventually lead to increase in the cortisol through increase the level of ACTH and growth hormone. If further decrease in the blood glucose level occurs without recognition, in this case the patient will pass into deep coma. Now, the previous figures are actually dynamic, they're not absolute. In other words, certain patients, especially who are having long-standing diabetes, sometimes they pass into the symptoms, the frank symptoms of hypoglycemia at a very high level, because the explanation for this long-standing diabetes and a continuous elevation of the blood sugar, it actually makes the brain very sensitive and vulnerable to pass into the symptoms of hypoglycemia at a level which is actually considered to be normal in a normal person who is not diabetic. For example, let's assume that we are having a patient with type 2 diabetes who has been uncontrolled for a period of many years and is having, for example, an average blood glucose level of 300 milligrams. In this situation, if the patient is receiving big dose of insulin or oral hypoglycemics, and if we assume that the blood glucose level will drop from 300 into 150, this level, which is 150 for this patient, will make him actually pass into a clinical syndrome of hypoglycemia. This is an unusual situation, but it is explained by the fact that long-standing hyperglycemia, it puts the brain at a sensitive situation in which it will pass into the symptoms of hypoglycemia at a level which can be considered a normal or even high for a normal person. Clinical features of hypoglycemia include the sympathoadrenal and neuroglycopenic. Sympathoadrenal or autonomic activation, it includes pallor, tachycardia, and widened pulse pressure, sweating, and anxiety. The neuroglycopenic symptoms, in which the direct effect of the low blood glucose is exerted on the central nervous system, it includes fatigue, dizziness, headache, confusion, or even deep coma, and also sometimes convulsions. What is the treatment of hypoglycemia? If the patient is conscious, the patient should be given the readily absorbable carbohydrates, preferably administered by the oral in the form of beverages or any glucose-containing drinks. And if the patient is having altered consciousness level, intravenous dextrose should be administered immediately. And there is a word of caution here, because if we are having a patient in which we suspect that the hypoglycemia was induced by oral hypoglycemic drugs, the continuous infusion is the best policy, and the patient should be kept under observation, and we should keep him provided with the infusion by the intravenous dextrose because of the long half-life of the sulfonylurea. Finally, a very effective treatment for treating hypoglycemia is administration of glucagon, which is available in the form of shots, and one single shot of 1 milligram intramuscular or subcutaneous will be quite enough for reversing of the hypoglycemia. This is the end of the part 5, and in the second part, which is part 6, we shall be discussing the final item of this series, in which we will be discussing the chronic complications of diabetes.